been doing for back pain patients, whether it could be X-ray, whether it could be MRI, CT scan, SPECT scan, or scintigraphy. So I would like to ask Dr. Bhilare, what modality of investigation would you ask for if a patient presents to you with chronic back pain?
Thank you, Dr. Priya. I think that's an excellent question. And probably that's a question every spine surgeon is looking answer for. So facet joint pain most of the time, or facet joint arthropathy leading to a chronic low back pain, is a difficult entity to identify. Most of the time it's an identification or a diagnosis of exclusion. So we have to have an area of investigation in the form of x-rays to rule out a chronic pathology, or you might have to require an MRI to rule out any disc related back pain, or it can be any ligament or paraspinal problem leading to similar kind of a back pain. The best investigation, as far as literature is concerned, the best investigation to identify a facet joint, to identify their orientation and the articular cartilage, is always a CT scan. So it has a slight edge over an MRI, but MRI is mainly to rule out the other causes. So you cannot just rely many a times you see a patient having a chronic low back pain, but then the patient has a facet joint arthropathy. It is at multiple level, and you don't know which of the facet joints are really causing the pain. And along with that, sometimes you can see an accelerated degeneration of the disc anteriorly, and you don't know whether that thing is from anterior part or not. So yes, like any other disease, we start with history, we start with clinical examinations. Unfortunately, for a facet joint pain, there is no a clear answer, no clear provocative test which can demonstrate or re-elicit the same kind of facet-related pain. In literature, there are some historical representation of some tests like a chem test, which is also called as a quadrant test or extension rotation test, since it basically relies on the fact that the axial or the facet joint is maximally loaded whenever there is an axial loading. Along with that, there is a rotation. So if you do extension and axial rotation, that is the maximum time the facets are loaded. And if you can regenerate a similar kind of a pain, then you can label that probably it is again from the facet joint. Unfortunately, the only provocative test we have for a facet joint is not a very highly sensitive test, neither a very specific test. So their sensitivity and specificity lies in the range of 60 to 70. And to have a screening low sensitivity doesn't serve the purpose. So clinically, it's very difficult to diagnose, and we have to rely on the higher investigation in the form of X-ray, MRI, and CT scan. Most of the time, we rule out the other causes, and if at all, if the patient is complaining of paraspinal region pain, if at all you can elicit tenderness along the facet region or on the transverse process, and the MRI or the CT scan suggests that there is an accelerated facetal arthropathy, we can label it. But the gold standard and always remains none of these tests which is mentioned, which is actually the facet joint block. So facet joint block is not only a therapeutic modality, but it's also a gold standard test to diagnose whether the patient is having a chronic low back pain and the cause is in the facet joint. So scintigraphy have been tried multiple times, have not given a very fruitful or a favorable results as far as the diagnosis is concerned. Hence, we have to rely in our clinical practice to rely more on the facet joint blocks or a medial branch block to see whether the patient is getting better, the facet joint or a medial branch block, and see whether the patient is really pain free.
Yes. I think with SPECT scan, we can know whether there is any active inflammation in the CTs, active inflammation in the facet joint, and we can know whether that joint can be painful or not. Because see, in MRI, if we get to know that there is degeneration, but we are not very sure that this facet joint would be giving pain or not. Because if I do my own MRI right now, I may be having a lot of degeneration in my spine, because having degenerative changes in the spine may not indicate that it is the pain generator.
Yeah.
So that's where you mentioned about the diagnostic blocks.
So that's the problem with the facet joint pain. I think till now we have in spine for more than a century now, and people are still not sure whether is there any test which can fruitfully identify the cause of pain being the facet joint. The problem, multiple pain generators you have in spine, and to narrow it down to facet joint is really very difficulty. And this part two, the dilemma is the treatment part. I think you're coming on that, so that time we'll discuss, because there is no clarity in the treatment either. So just diagnosing that the patient has a facet joint pain and you're not doing anything better other than giving a pain block doesn't serve the purpose or doesn't give a cost effective nature of so many investigations being done to identify and tell that the patient has a facet joint, and then do not more but just give a facet joint block. So that I don't think any of this test is so cost effective.
Dr. Viral, what are your views on this?
On the facet joint block, you mean to say, or is how to
No,
diagnose?
about the investigations, do you agree with the discussion or you have some other views on?
No, I agree a lot with what sir has said, but see, because in when a patient presents to us in a clinic, we are not hell bent on getting investigations and proving our point. Basically, what our aim is to give functional good pain relief and good functional rehabilitation of that patient. We can explain to the patient that these are 1, 2, 3, 4, 5 probable causes, and out of that we can tick, say, these 2 or 3 we are able to tick in your case, and we will start treating each and every one by one. There will be hardly ever any patient who will come with only facet. So there will be a disc, there will be some muscle issues, there will be a muscle spasm related to it, then there will be a lot of other issues because of having a restricted lifestyle or sedentary lifestyle. So a lot of things can help. So directly before we go on to an investigation or any procedure also, we will be maybe seeing that patient 2 or 3 times in our clinic, and we will giving a conservative trial of physiotherapy. So that's how we will gradually narrow down on one part, one of them, and we'll just tick the boxes, say this was right, this has been corrected, this has probably improved, and now this is the only thing that is left to treat. Somehow I think that will help us reach to a conclusion now that facet is the cause of the problem.
Now, my next
Yeah, I
question is
agree.
to Dr. Shanawaz.
One last point, madam.
Hmm.
I forgot to tell actually. Before labeling any patient that the patient is facetogenic related pain, I always take a psychosomatic analysis or a psychological
Right,
analysis.
right.
Always in all of the patients, whenever I am not sure whether the pain generator is a facet joint pain, then I would like to get their psychosocial analysis done before labeling the patient as having an facet related pain.
Yes, because it has been very much demonstrated that patients who are having psychological trauma are more prone to get the neck and back pain because they are always keeping their muscles tight. So most of the time they have muscular pain. It's not that their pain is
Yeah.
psychological, but muscular component is much more in those
and
patients.
and
Yeah,
not only
yeah,
that,
yeah.
when you do the psychological analysis, you are coming to a conclusion about what is the patient's mindset and what is the patient going to expect from you in terms of relief. So whether this patient will be happy with a 50% relief, or this is the patient who is going to keep calling you in the night at 12 o'clock also if there is very little pain. So this when and this when we start seeing patients and we keep talking to them, and when they keep following up, we come to know their history and we come to know how they are going to behave. Somehow or the other, clinicians come to know that this patient will be happy with even 50% relief, and this patient may not be happy with even a 90% relief. He is the one who wants 100% relief.
My next question goes to Dr. Shahnawaz. Dr. Shahnawaz, is there any correlation between radiological findings and radio frequency ablation outcomes? Because before doing radio frequency ablation, we always get an MRI or CT scan done. So, is there any correlation? Are you suspecting anything that radiological findings, this much radiological finding is there, patient will have this much relief? Is there any correlation?
As we go for the radiological assessment of the patient, first we clinically try to diagnose the patient with the clinical criteria only. And once we advise this, sorry, in the radiological investigations, ideally we ask for the MRI just to show, just to rule out other causes of the low back pain, as well as to rule out the red flags also, and to show the relation of the facetal joint arthropathy with the impinged nerve or foramen. So as far as the radio frequency ablation is concerned, the outcome is concerned, we are targeting the nerve supplying the facet joint in radio frequency ablation. So we are not targeting the pain generator. Actually, we are targeting the pain transmitter, which is transmitting the pain from the generator to the spinal cord and up in upward way to the brain. So there is, I don't think there is any correlation between the radiological finding as well as the radio frequency ablation outcome. Whatever the grade of arthropathy degeneration is there, from the X-ray point of view or from the CT scan point of view, or whatever the finding in the MRI, if we are suspecting that we are confirmed that the pain generator is the facet joint, and the median branch block we have already given, and it was found to be positive. So we can go for radio frequency ablation, and we can expect more than 6 months to 1 year of pain relief.
So considering our previous discussion, these are the levels of degeneration which are based on MRI. Grade 0 being normal zygapophyseal joints where width is around 2 to 4 mm. In grade 1, joint space narrowing is there. In grade 2, there is narrowing of joint space with subarticular erosions and osteophyte formation. And grade 3, there is narrowing of the joint space and there is hypertrophy of the articular processes, subarticular bone erosions is being seen. Now going on to treatment options. So first about the conservative treatment, my question goes to Dr. Divakar. Dr. Divakar, what would be your line of management in case of facet joint arthropathy when patient presents to you for the first time?
After coming to a fair idea that the pain is facet joint, we start them on conservative management like any other for any other pain situation. We start them on analgesics, mostly NSAIDs to begin with, unless patient is having any contraindications for that, and pain physio modalities like IFT and TENS and ultrasound massage. And we at least for 3 weeks of conservative management, and if with that patient is getting pain relief, then go for the muscle strengthening exercises, that is that physio rehab protocol. If patient is responding for that, we will continue that. At some point we'll stop the analgesics and continue on physio, mostly the exercise therapy. And if patient is not getting better with that, then we might consider therapeutic facet joint block or medial branch blocks.
So Dr. Bhilare, do you agree with the conservative management which has been told by Dr. Divakar, or would you like to add something else?
So I agree partially with Dr. Divakar that conservative line of management, they usually have pain extension, and they usually have pain on axial loading along with the rotation. So for the initial phases, we tell them to avoid those activities in extension as well as rotational activities as far as possible. And once the pain threshold has improved or the pain has decreased to a considerable extent, that is the time for the McKenzie type of exercises, in which it's basically strengthening their core, reinforcing capsules, the longissimus and the multifidus muscle. So that is a treatment modality. In my book, I usually keep the facet joint block as well as the medial branch block as a part of conservative management, because these are the modalities where we don't intervene surgically, we don't remove any facet as such, but we try to control the pain. Once the pain is controlled, the patient usually tries to do the physiotherapy in a better way. So in my book, I still consider a facet joint block or a medial branch block along with a conservative management.
Agreed.
Dr. Viral, would you like to add something?
Of course, we even if you're trying to offer a conservative trial and you're asking to asking the patient to do some physiotherapy, some movements. If the patient is in pain, definitely he or she is not going to do or perform the physiotherapy to the optimum level. So definitely, sometimes you may have to institute a block initially and then follow it up with your analgesics and follow. Once there is a good pain relief, then automatically you will reinforce the patient to go for physiotherapy and back strengthening and movement exercises, and then ensure his good functional outcome in that patient. So even the blocks can be given first without any conservative trial if the patient has really severe pain, and if you are having a good investigation to support your diagnosis, and clinically also if you feel that the patient really needs a block first before they go on to exercises or a conservative trial.
So in conservative management, my first treatment would be medications. So Dr. Shahnawaz, apart from NSAIDs, what other medications would you consider in the patient who has presented to you with severe backache because of the query facetogenic pain? Your mic, Shahnawaz, please unmute yourself.
Sorry. See, when we are suspecting the facetogenic pain, then at that time we have two things in our mind, either degeneration or inflammation. So depending upon the patient's presentation and depending upon the other history, we have to proceed. Like if we are suspecting inflammation is more than the degeneration, then we can go for the low dose steroids along with the NSAIDs, as well as we get since these patients are having chronic low back pain, so they need the neuromodulators in the form of gabapentins or like pregabalin or gabapentin. So along with NSAIDs, I would like to go with other modalities like neuromodulator as well as low dose steroid if needed. If not contraindicated, if there is no signs of any infection, then we can use some low dose steroid for few days. It can help the patient.
Any role of opioids?
Opioid we can use the if NSAIDs are contraindicated, then we can use opioid this weak opioids like tramadol or dependadol. But the strong opioids like morphine, fentanyl, or buprenorphine, I don't think that they will be helpful much in such cases.
So I agree with all of you. Medications in the form of NSAIDs and any pain which has lasted for more than 3 months is likely to have neuropathic components. So I would better start with anti-neuropathic medications like gabapentin, pregabalin, amitriptyline, nortriptyline, etc. And if needed, opioid also. Short duration of opioid, not on long term. Hit and cold therapy depending on the duration of pain. If patient has acute onset of pain, I would better go for cold therapy. If patient has chronic pain, I would go for heat therapy. I would like to support the lumbar curve by changing the ergonomics, because it changes the way the facets get loaded. I would ask the patient to avoid activities that aggravate pain, like prolonged sitting. Staying active is the key. No bed rest is advised for facetogenic pain. Low impact activities like walking for at least 15 minutes a day for at least 4 to 5 days a week. Supportive brace, I would not go for supportive brace. I hope you people agree with my view in this. Supportive brace, Dr. Bilare, any role in facetogenic pain?
Absolutely. No, it doesn't have. In fact, there are now level 1 and 2 evidence suggesting that supportive braces are not useful in most of our PIVD cases also. So I completely agree that the facetogenic back pain is more of a psychological relief than it does anything to the patient.
It will in fact do worse to the patient because it will weaken the muscles and further
Paraspinal
instability.
muscles. Yeah, I agree.
And physical modality, like Dr. Divakar has explained, first go with the stretching, and thereafter, once pain is less, we go with the core strengthening exercises. Uh, Now about interventional pain management, I think most of you have already talked about facet joint injections and medial branch blocks. Uh, there has been dilemma that whether to go for facet injections or whether to go for medial branch blocks. So, Dr. Viral, what are your views on this? Whenever a patient of degenerative facetal arthropathy will present to you, will you go for medial branch block, or you would want to go for facetal joint injection, intra-articular injection?
uh, where we have to first consider what we are looking at in this patient, what level of pain he is in, and what are the MRI findings, and what is the patient desirous of in terms of outcome. We have to offer him the options, and the patient is the boss. He will choose what he thinks is right for him. So we cannot give him n number of options, but we have to narrow down on one or two options. So I personally would like to do a facet joint injection if I am seeing a good amount of inflammation on the MRI, if there is in the on the T2 weighted image, if there is a lot of fluid in the joint, my personal choice would be to do a facet injection there. That helps in two things. One is we will try to treat it by injecting a small amount of steroid, reduce the inflammation, and that is where the pain generator is. Basically, it is because of the inflamed joint. Even if we are not able to deposit drug inside the joint, if we are able to puncture the capsule, it will lead to some amount of loss of inflammatory fluid, and that will also help the patient to a great extent. The pain relief will be great. Whereas if you are looking at medial branch blocks, then you need to have a patient who understands his role in the treatment. When you are giving a diagnostic block at say 1 or 2 levels, you need to have a patient who is smart enough to get back to you and give you a good feedback that I had this kind of pain now, doctor, this is relieved, but my leg pain is still there, or probably so that is how I think you will choose your intervention, whether you go for a block or a facet joint injection. But if you have already treated for the, no patient will come with only facet, so there will be a disc, there will be some ligamentum hypertrophy, there will be some canal stenosis. So if you have already say treated for the root block, and if that is successful, but there is still some amount of pain, and now you are zeroed down on the facet, maybe then you can go for a median branch block if you are planning for a long-term relief, like with your planning for a radio frequency ablation. So that will help you two things. It will confirm your diagnosis and help you plan the next procedure. And even the median branch block can be therapeutic in most of the cases, though it is basically diagnostic, but it can give good amount of relief. Maybe some patients have relief up to 6 to 9 months after a median branch block. So that is how you will decide on your choice of treatment. And of course, I'm not talking about the finances, that also is an issue in our country, where such procedures are not covered under insurance and not covered under Mediclaim many times. So patient is paying from the pocket, so he needs to understand that if he undergoing is on lying on the OT table and is in the suit and is undergoing some intervention, what kind of relief he needs to get.
Dr. Divakar, my next question goes to you. Would you like to use any?
It's done under ultrasound guidance also, but we in our hospital we don't use that. We use mostly X-ray guidance.
Yes. Dr. Shahnawaz, any advantage of X-ray over ultrasound or ultrasound over X-ray in case of facet joint injections?
Actually, I don't have much experience about the ultrasound, frankly speaking. We usually use the fluoroscopy IATV guidance only for this kind of blocks. So for me, it's always preferable to use fluoroscopy rather than ultrasound. But I can say that with the use of ultrasound, you are not you are limiting the radiological exposure of the patient. So the ultrasound is preferable if it is in the hands of the experienced person.
Also, we can avoid neurological as well as vascular injuries with ultrasound because we can see them clearly. The only
And
disadvantage is learning curve, I would say.
Yeah.
And it can be done as an office procedure also. If you have a OPD with you have a ultrasound, you don't need to post the patient into OT and take him under the CM. And so if you have done a procedure and there is a good amount of relief, but then there is some problem with the facet, and you think now this is what I want to target. Even in your OPD, if you are able to use the ultrasound, you can do the block and ensure that there is some relief. So you can do it as a diagnostic block.
Dr. Bilare, how much volume of drug would you be giving in facetal blocks?
So the volume of drug is a matter of again, but the drug dosage, if you are giving a triamcinolone or if you are giving a decometrol, so somewhere around 40 mg of methylprednisolone can be, or decometrol can be given. The volume would be not more than 4 ml. So already the content of the volume in a normal facet joint is not more than 2 ml. So already between 1 to 1.5. At all, you are giving a facet joint intraarticular block, it should not be more than 2 ml.
Any complications of facet joint injections you would like to highlight?
So whenever there is a doubt whether if you're not into the facet joint, we'll to dye inside with which is an iohexol 300 dye. See the facet joint orientation. See whether you are really intraarticular or is the facet. If the needle is outside the facet joint, and once you confirm your position, you can easily inject it. But an inadvertent vascular or a nerve root injury, if you are doing it in a CM guidance, and if you don't take an AP or a lateral view, you might think you are in the facet. We are actually near the foramen inside the nerve, and if you put the injection carelessly, and if you inject the drug into the vascular, it can cause vascular thrombosis. Because most of the drugs which are using, most of the steroids are particulate steroids, and it can clot the vessel and cause vascular injury. If at all you are giving at a layer somewhere around L1 or L2 level, you have to be deadly sure before injecting the drug, because very rarely you can have a arteria aqueous or arteria magna, which can start as low as that level. There are few case reports, discrete case reports where the origin has been reported as low as alpha S1 junction, which is a very rare. And if that sole artery you thrombose, then you can have as deadly as a paraplegia to the patient. Now that is something which is not absolutely acceptable. So higher lumbar facet, I am 100% before injecting, and I should be 100% on an APL and a lat. If you are not sure of your needle placement, do a dye and then only inject the drug.
Dr. Shanavas, my next question is to you. While giving medial branch blocks, I wish to say diagnostic medial branch blocks, how much volume of drug would you give?
See, ideally for diagnostic median branch block, we use zero point 0.2 to zero point 0.5 ml of local anesthetic. We are very near to the neural foramen. So if we use the larger volume, it may get spilled into the foramen and it can block the nerve root also. So ideal volume is around 0.2 to 0.5, not more than that.
Now, other interventional pain management would be radiofrequency ablation of medial branch block. So, what would be your endpoints while doing radiofrequency ablation under CARM guidance?
For radiofrequency ablation. See, ideal needle position for radiofrequency ablation, the needle should be parallel to the median branch to get better ablation of the now. So we can target when it traverses the groove between the transverse process and superior articular process. So tip of the needle must be positioned along the lateral neck of the superior articular process, not in the groove. Not exactly this is the groove. Suppose this is the transverse process, this is the superior articular process. So our needle should not be exactly into the groove, but it should be on the lateral neck of the superior articular process, because the nerve is coming through, coming in between the mammary accessory ligament and the superior articular process. So we can target for the radio frequency ablation. We can target our median branch uh, here only.
Dr. Viral, my next question to you. If a patient, you know that your patient has bilateral facetal involvement with the diagnostic block, you have already given diagnostic block. Uh, but would you do bilateral radio frequency ablation in that case?
Mm, Bilateral radio frequency ablation should not be done according to me, because even with very good needle placement, you are going to cause some amount of injury to the supply of the multifidus muscle also. So if you are doing blocks on radio frequency ablation in the same sitting on both sides, that the patient may land up with some instability because of loss of function of these paraspinal muscles. These are important muscles. So I think you should stage this procedure. And also you cannot ensure your success of your procedure if you're doing on two sides and patient. Basically what, when you're doing a procedure, your endpoint is needle placement and all that is okay. At the end, you want to assess the patient's pain relief. If you have done procedure on both sides, and if patient is saying 30-40% relief on one side and no relief on other, you are confused whether it was correct, the procedure worked for him or not. So ideally do it on one side, let the patient get good pain relief on that side, assess your performance of the block or the radio frequency ablation, and then go for the next side. This is difficult to explain to the patient, because practically patient will have to come twice or maybe thrice to your clinic or your OT. But if you really want a good outcome, if you want to really justify your procedure, and if you want to have a prolonged relief in any patient, I think you should do only on one side, and then hope for the best for the other side.
Dr. Shahnawaz, before proceeding to RFA, how many diagnostic blocks would you like to give to the patient? Because literature says n
So,
number of things which we are
uh,
not very.
considering the literature, considering the studies and recommendations by different societies, ideally we should go for dual block before going for the radiofrequency ablation. And this dual block should be done with the help of different local anesthetics, the short duration local anesthetic, and the long duration local anesthetic like lidocaine and bupivacaine. So ideally, and if we are following the guidelines, then we have to go for with the dual block. But considering other factors, clinically, drop rate increases with the patients, patient satisfaction, the cost effectiveness of the procedures. Uh, Considering all these factors, we at least we can do the on table before going for RFA. We can do on table diagnostic block just before radio frequency, and if it gives relief of around 50%, then we can go for radio frequency ablation.
But Dr. Shahnawaz, if I have given local anesthetic for the diagnostic block, while doing RF, I may not be able to check the motor and sensory
See, if if
examination.
if you are planning for radio frequency ablation, and if you have explained all the pros and cons to the patient, and patient is ready for the radio frequency ablation, you can use the same needle, radio frequency ablation needle, for the diagnostic block also. And you can position your needle along the parallel to the nerve. The tip should be parallel to the nerve, and you can check the sensory and motor stimulation, and then once you are confirmed that your needle is in the place, you can go for a diagnostic block at that time, and wait for 15 to 20 minutes. Ask the patient if he or she is comfortable with this diagnostic block, then you can directly go for the radio frequency ablation also.
Okay, got it. Dr. Viral, any role of cooled radio frequency in treating facetogenic pain?
Yeah, there are recent lot of case reports and even some studies who have shown benefit of cooled radio frequency ablation. Only thing you need to take is a smaller active tip. So your active tip should be only 2 millimeters, and your needle placement should be very accurate, because with cooled radio frequency you are going to generate a larger lesion of the nerve. So in case if you're even a little anterior or little lateral, you might be going very close to the nerve root. and which you do not want to ablate. So you want to ablate only the medial branch. So because of because of the larger lesion, you can, if you can cover for the variable anatomy of the median branch in this procedure. So cool frequency has a role, but you have to use a smaller tip and be accurate again.
I agree. Any other modality, interventional pain management modality, would you like to mention? Dr. Viral, Dr. Shanavas, from my
Uh,
side.
like you already mentioned about the facet joint injection and median branch block and radio frequency ablation.
That's it.
And
One
apart
more
from this, we can use the uh, cryo
ablation, cryo
cryo
ablation.
Yeah.
ablations. But they produces larger reason. So the reason to avoid this kind of interventional procedure, because we are very near to the nerve root. So it's better to avoid this kind of procedures.
Uh, Another one which I would like to mention specially is ultrasound guided dry needling. Uh, Dry needling, because any joint pain has to have surrounding muscles in spasm. So if I'm treating the joint, I need to treat the muscles also, because treating only joint is not going to relax the muscles altogether. So that's why ultrasound guided dry needling has also to be done if muscles have not relaxed completely after doing our all the interventions. And most of the cases, most of the times, we need to do this ultrasound guided dry needling after the interventions to have the prolonged effect and 100% result.
And of course, when you are doing your procedure, also in many patients, you will definitely realize the muscle spasm, because your needle maneuvering will be difficult. So this definitely can help, and none of the procedures is going to be a magical relief that patient is out of the OT and pain free. So there is each of these procedures takes some time. In the meanwhile, if you do a few sessions of dry needling, that can help also the muscle spasm to be relieved and help the patient to do better physiotherapy and better exercises and give better relief overall.
Uh, and about surgical management, but before going to surgical management, I would like to just show the few pictures. This is the CM picture of intraarticular steroid injection, where needle being put in the lower end of the facet, and radiographic dye is being seen here. Medial branch block, you can see the exact location of the needle entry, bullseye entry. Superior articular process, the transverse process, and exactly at the junction. We go exactly at the junction of superior articular process and transverse process. About radio frequency ablation, you can see the needle position exactly as medial branch block. But in order to go parallel to the nerve, we have to take oblique entry. Here the entry is bullseye, but I need to go little oblique in order to go to parallel to the nerve and have better lesion. In exact bang AP view, we need to be lateral to the facetal line to avoid damaging the nerve root. And in lateral view, we have to be far behind the superior articular process. We should not be in the foramen. Now about complications of radio frequency ablation. We may have temporary localized pain, which patient needs to be counseled about previous hand. Neuritic pain may be there after radio frequency ablation. It can present as dysesthesia, hypoesthesia, and exacerbated pain. And there can occur displacement of the electrodes, which will lead to damage to the nerve root directly. So, Dr. Shahnawaz, if your patient has neuritic pain, or what will you do to, will you counsel the patient beforehand about the neuritic pain? Dr. Shahnawaz, please unmute yourself.
Yes, of course, we have to counsel the patient beforehand that once you go for radio frequency ablation, you may have some pain increase after the procedure for few days, and because we are ablating the nerve can cry out, and then neuritic pain can occur. So we have to explain all these things beforehand before going to the procedure. Once we have done the procedure, we have to keep patient on neuromodulators for few days, for longer days.
Uh, So another complication which I would like to mention specially is, as already been discussed by Dr. Viral, is the multifidus atrophy after bilateral RF. Here is the case report, beautiful case report presented by Dr. Lakshmi Vas. Here patient had undergone bilateral radiofrequency ablation at L1, L2, L2, L3 and L5, S1, and patient immediately after the procedure, patient went into this posture of camptocormia. Because spinal extensors were all weak, flexors had taken over, so patient trunk was bent over the lower limb. And after few sessions of dry needling, she is standing erect and her pain is gone, absolutely. Yeah, about surgical management, Dr. Bilare, is there any role of surgery in pure facetogenic pain?
Oh, I think the answer would be no. That we don't treat the patient primarily because the patient has a facet-related pain. The only facet-related surgery that we can do is a facet dislocation. Unless a patient has a facet dislocation, we don't venture into facet-related pain. The reason being there are too many facet uh, generations in the pain generators, and one of them can be facet. So we cannot assure the patient that if you take away the facet joint, you treat the facet joint and the pain can be relieved. There are few attempts which are being done in the form of facet joint arthroplasty. Like any other joint arthritis, we can replace the joint and theoretically should be pain free. But then the facet joint arthroplasty have started somewhere around 20 years back. It has never picked up the light, and now it is absolutely not done in most of the institutes or most of the centers which started those procedures. It's difficult. Secondly, there are a lot of failures because of not a one pain generator where the facets are involved. You cannot narrow it to that pain generator. So that's why the facet related surgeries are not in vogue. But yes, if along with that, if the patient has a radiculopathy, if the patient has so much arthropathy, so much so that the foramen gets stenosed and the patient has radiculopathy, or if there is a facet joint synovitis and a synovial cyst compressing or sitting on an exiting nerve root, that is the only time we usually go for a surgery. And most of the time, again, facetal arthropathy leading to a foraminal stenosis or a canal stenosis or a lateral recess stenosis doesn't tell you that you have to undergo facet excision and fusion surgeries. If we can sacrifice the medial one third of the facet and make the nerve root free, or we can approach the facet joints from the canal and remove the facet joint, extend the pain. If the nerve root is free, we need not remove the facet completely. We can sit on the facet, let the facet joint degenerate, because as per the Cricardi-Willis theory, ultimately the facet joint has to settle. Anteriorly, if the disc settles down, collapses, then ultimately even the facet-related degeneration will also settle. So these are theoretically the surgical indications, but in my practice, not till date, I have not operated a patient just because the patient had a facet joint arthropathy. Even if on a diagnostic modality, I diagnose that the patient has a facet joint arthropathy, I would like to repeat the diagnostic or the therapeutic injection in their cases and stress on conservative line of management. Until date, I have not operated even a single patient of facet joint arthropathy.
Dr. Divakar, like Dr. Pramod has said, that he would like to go for facet injection and repeat the injection because surgery is not indicated in those cases. Isolated facetal pain, you said, right? So, how frequently you would like to give facetal blocks? If patient presents to you, say within 2 months of your facet injection, would you repeat the block?
Yeah, we can repeat it, assuming that first injection the effect of first injection have not lasted much. We can repeat the injection.
Okay. How many times a year you can? What is your protocol of repeating the injections? Maximum, how many times you will repeat the injection in a year?
Maybe thrice.
Okay.
Because, yeah.
Dr. Viral, any other views on this from your side?
basically we need to calculate the annual dose of steroid that which we are giving. So it is say 240 milligrams for a person. So if you are given 60 milligram in one block totally, you can do the procedure 4 times in a year. Maybe after 3 months you can repeat. But definitely when you need to repeat the procedure, you need to recheck your diagnosis. You need to also recheck whether your patient is following the other lifestyle modifications and other physiotherapy exercises properly, and whether he is ensuring his own rehabilitation. Just by him coming to the clinic and you giving blocks is not going to work. So there is somewhere you have to enforce this on the patient. Maybe you can be strict with the patient, or maybe you can be so good enough that you motivate him to do whatever is needed. Just repeating the blocks is not going to help.
Dr. Bilare, if say a patient you have given facetal block has come back to you after a month, he had very good relief for a month. He had undergone good rehabilitation, but his pain has come back. So, would you consider repeat block or would you consider radio frequency ablation in these cases? Because if patient is going to come back after every month, so how many times you are going to repeat the block?
So I think that's a very good question. But and we do get such patients who has undergone a facet joint block, and they reported a temporary relief for 3 to 4 weeks, and then they come back. Most of the time demanding for injection because they were so better with the first injection that they would like to take another injection. But I usually discourage them from getting an injection not before 6 months. I usually tell them, you go ahead, you now consider, now that your pain was relieved, you were better, you concentrate on your core strengthening exercises, postural corrections, weight reduction. So whatever modifiable factors which can lead to this facetal loading, something like an high BMI, you need to decrease the BMI. If there is a history of any profession which can cause recurrent trauma to the facet joint or a micro trauma to the facet joint, then I tell them to slightly modify your workplace, do some ergonomic training, and better to rely on that than repeating an injection. So I usually don't repeat the injection before 6 months. And if at all the patient comes back with a pain of after 6 months, such demanding or complaining that it was better and then now that has repeated, I usually send it to you. So you can go ahead and give the radio frequency ablation. I personally don't do a RFA ablation. I usually refer it to a pain specialist. But the first injection, I need to do it most of the time, mainly because of the diagnostic reason and not because of the therapeutic reason. I want to know pain was there. Was it because of the facet joint? Once I had got a relief from the pain or reported relief from the patient, then I usually to a pain specialist and I tell them to take over, because this is you deal with more of RFA ablation. I am not a big uh, practitioner as far as RFA ablation is concerned.
Uh, Thank you, Dr. Pramod. Uh, Now, I would like to go for a case discussion. Dr. Shahnawaz, I want here is a patient, a 55-year-old daily wage worker who has presented with low back pain since a year. He has received medications in the form of NSAIDs and he has undergone physiotherapy. He did have temporary relief for 3 months, but his pain has again come back with the same intensity. His spine movements like extension and lateral rotation are painful. He has paraspinal tenderness. So how would be your line of management in this case?
See, since this patient he came for the first time to me with these complaints and with this examination, I would suspect the facet joint as a pain generator first, and I would like to go with the conservative therapy first. If a patient is ready for that, we can go for like we can advise the NSAIDs along with other medications, as I already told, like gabapentin or pregabalin, or along with the some muscle relaxant if we find the focal muscle spasm, along with the NSAIDs. And we can ask for the ergonomic modification along with the physical therapy. Physical therapy, we can use the cold packs as well as the modalities like ultrasound and IFT to the back. Uh, so I would proceed with this conservative therapy only first.
What about you, Dr. Viral? Would you like to go the same way or you have some different plans? Because patient has
Of
already
course.
received conservative treatment for 3 months
Yeah,
and
yeah,
he had good relief.
but definitely there is something more that you can do before you jump onto your blocks, or you jump onto the diagnostic blocks or any injection. He can, if he is convinced enough, if you feel that patient will follow the regime, I think he merits a conservative trial over here further.
Any other views, Dr. Divakar?
Yeah.
Ah, see.
Actually, what was the question, please?
See, we had a patient who is 55-year-old Delhi wage worker and he has received conservative treatment and he had good relief with conservative treatment for 3 months, but his pain has again come back. So Dr. Viral and Dr. Shahnawaz says that they would still want to go with the conservative treatment again. What is your view on this? You would want to go with the facetal block, median branch block, or you would also want to give a trial of conservative treatment again?
We would go for a block,
So you would prefer facetal block or medial branch block?
median branch block.
Dr. Billare?
Any investigations have been done in the form of an MRI or a CT scan?
No, not yet.
So then I would like to investigate the patient. This is a very classical scenario in most of our patient presenting to our outpatient clinic, that the patient has been seen multiple times at outside hospital or an outside clinic or in peripheral hospital. Then he comes with a history of chronic low back pain ranging from 3 months, 2 years, had temporary relief with some painkillers. They classically tell that as long as the pain medications are on, they are better. But once the pain starts getting or the pain relief starts, it's not that much. Once the painkillers are finished, they would like to visit another doctor to get another set of pain medication. These usually, if a conservative treatment tried for a 3 months, then I would like to investigate the patient. If the patient reports back with a recurrence of pain, I will first make sure the patient has no other problems other than facet joint arthropathy leading to this kind of a pain. Because as I said earlier, for me, the facet joint arthropathy leading to pain is a diagnosis of exclusion. I need to find out for sure that the patient has nothing going around, and if everything is clear, if the provocative test or the MRI or clinical background suggests that the patient is probably having a facet related pain, at this time I would like to intervene with the help of facet joint block or a medial branch block.
So here is a second scenario, Dr. Billare. A 75-year-old male who has been complaining of back pain since 15 years and he has a radicular pain in left lower extremity since 3 years. He was diagnosed to have facetal pain 5 years back after giving diagnostic block and he underwent RFA and he had good relief for 2 years, but thereafter he has again started getting back the pain in the back as well as lower extremity. Previously 15 years back he only had back pain, but since last 2 years he has lower extremity pain also, and this is his MRI, cross-sectional MRI.
Yeah, so that's an axial.
Yeah.
So a good of elderly gentleman presenting with a long-standing back pain, which got better with a facet joint block or a medial branch block in his case. But then now a new set of symptom which has developed is a radicular symptom. In this case, as being done, I would definitely go ahead with an MRI. Along with that, I would like to get a flexion extension views of the lumbar spine. Here you can see there is a lateral recess stenosis there is on an axial cut, the left-sided arrow suggests there is a facetal arthropathy. Along with that, there is a ligamentum hypertrophy which is there, and the three lease zones, which are the entry, the proper, and the exit zone, all are getting compromised. Mainly, this suggests the lateral recess stenosis, more so on the left lower limb, which corresponds to his finding that he has a left lower limb pain. If the left lower limb pain is, in his case, is recent in onset, I would still like to do a conservative enough management in this case. Okay. Before advising, always a pain block is an option. As I said earlier, that is a part of my conservative line of management. If the pain is not that much, I would like to advise a patient on medications, physiotherapy, as you said, postural training, and some exercises. If the patient is having pain to a tune of a VAS score being 8, 9, 10, in that case, I would like to give a selective nerve root block at that level. Along with that, I would like to give a facet joint block.
Good enough. But if say your patient does not respond to the facetal and nerve root block, what would be your further management?
So here there is one more finding, which is actually, if you see the facet joint, especially on the left side, the facet is getting sagittally oriented. So I won't be surprised if I get a listhesis at this level, especially on dynamic X-ray. And if the patient has listhesis on a dynamic X-ray, there is a documented lateral stenosis. Patient has been tried conservative line of management for a period of 6 to 12 weeks, got better or a temporary relief, and then again, if there is a recurrence of symptoms, then I usually open my card of surgical management. And in this case, I would still try to avoid a complete facetectomy if there is no instability. But if there is a demonstrable instability, then I would like to remove the facet, do a transforaminal lumbar interbody fusion at this level, and seeing if there is not much degeneration at an adjacent level, I would like to do a monosegmental one in these cases.
Anyone else would like to add to this overall discussion?
Uh, this patient was a 75-year-old gentleman, if I'm not wrong.
Yes.
So, before advising him for any such surgery, spine surgery, we need to look at his comorbidities, if he has any other comorbidities, and what is his functional status, and what is his expected goal of outcome. So, definitely, he merits a surgery if he is willing to, or is fit for it, and he can. He's desirous of such result. Otherwise, we can do a few blocks, gets relief for some time, gets physiotherapy. Again, you can repeat the block after a few months when there is recurrence of pain. So this time, this patient will also decide whether he needs to go for surgery. Very few patients are keen on a spine surgery, even if they are young. So in such an old patient with so many comorbidities and anesthesia complications, I think we have to decide on the functional expectations of the patient, how much expectation he has from the.
Yes.
So
That's
just a point here, I think Dr. Viral brought out an important point. It's not about treating an MRI. You treat a patient as a whole. So if the patient is 75-year-old on chronologically, but if the physiological age is somewhere around 60, his demands are high. The patient's comorbidity wise is not much comorbid, and he is of a ASS score 1 or 2 or maximum 3 in borderline cases. In those cases, we would like to put surgical option only after exhausting our conservative line of management.
Exactly.
I think in this case also, surgery would not be as a first line of management only if there is all conservative line of management in the form of physiotherapy, medications, block have been tried out. That is the time we usually, along with the demand of the patient. So if the patient is 75, but if the physiologically is 90-year-old and he just have to move from bathroom to his bed and bed to the bathroom, that is what his demands are. Then in these cases, we would like to avoid surgery. Again, the another important part we take into consideration in surgery in cases of facetal arthropathy leading to radiculopathy is actually the standing and a walking tolerance. If the patient is standing for 1 hour or so, walking for an hour or so, is hardly affecting his activity of daily living, then these cases are not ideal cases for surgery. Patient might demand for pain relief, but if it is causing pain on a scale of 0 to 10, somewhere around 4, 5, 5, and patients walking and standing tolerance are good, I think you can still try for conservative line of management. If at all patient demands a surgery, better to send it to your enemy than to yourself.
Uh, so just to conclude, we know that pain originating from the facet joint is being recognized as potential source of low back pain. There are no discrete historic and physical findings pathognomic for lumbar facet arthropathy. So we have to rely on diagnostic blocks, which can provide long-term as well as short-term relief, and subsequent and they help in subsequent neurolytic blocks, such as radiofrequency denervation. In carefully selected patients who fail conservative treatments, intraarticular steroid injections and radiofrequency denervations are the treatment options. And surgical procedures for pure facetogenic blocks like facetal arthroplasty are still in infancy. But yes, if patient has multiple pain generators, definitely surgery is an option after the conservative treatment fails. So that's it from my side. If anyone wants to add to anything to this discussion, most welcome.
Uh, I have one important point, and it is not clinical, but I think it is very practical. See, all our societies, whether it's a pain specialty or orthopedics or spine societies, I think we all should come together and go ahead and force the insurance companies, or present our cases in front of the insurance companies, that they should allow these procedures like a facet joint block or a diagnostic intervention to be reimbursed by insurance. And even if it is done on a daycare basis, like how cataract surgery, maybe 20, 30 years ago, they needed a day stay and admission. And today, insurance companies are reimbursing cataract surgeries on a daycare basis. I think if surgeons and pain physicians and all other faculty come together, and if we can put across a point, we are saving money for the insurance company also. Instead of a spine surgery, patient is paying for a facet or a root block. So patient is going to ultimately pay less, and the insurance company is saving on that. Definitely, these procedures need to be repeated. There have to be some guidelines how many times you are going to repeat and how many times the insurance is paying for it. But if the insurance companies come ahead and support us, and then we can really do two diagnostic blocks before doing an RFA. If patient is paying from his own pocket, he will not come thrice on the OT table for your satisfaction and for your clinical outcome. And that's how we may not be able to give enough papers into the future generation. Maybe 20, 30 years down the line, we won't have enough such studies. So this is something where we should all get together and do something for it.
I think ISSP is already working on it.
Yeah, definitely. But this surgical society, if they also support this move, it can be a big thing, because it can save a lot of difficulty in convincing the patient basically to go for a procedure. Really, that is the most underlying thing, that the finances, and that's how you decide your treatment. That is why you may do a root block and a diagnostic facet injection also in the same sitting, and then you definitely cannot tell whether your relief is because of the facet or because of the root block. But patient is happy, you are happy, and the story is over. I think something needs to change there. And
Definitely.
I tend to agree with Dr. Viral that diagnostic blocks are not being reimbursed by the insurance companies. Most of the therapeutic blocks, like the selective non-root block or the foraminal blocks, are being done, and we at Sancheti do follow and we do get it reimbursed from the insurance company. But those are the therapeutic ones. And as you said, the diagnostic essence of that block usually is not that great because the farmer coming from far off with a limited amount of money with him, and if you want to tell the patient, let me know whether it is coming from the nerve root, disc or facet, let me give that block which will cost you somewhere around 10 to 15,000, then the patient won't be very keen on opting that. You would rather say that you get me pain relief. I don't want to know where the pain is coming from. For them, they just understand one thing: they want pain-free life, and they don't want to know whether the facet joint is causing the pain, is the disc causing the pain, or the causing the pain. But I completely agree that will help us to mold the treatment modality to most of our patients. If at all the patient requires further intervention in the form of surgery, then we know that this was a pain generator, and probably if you treat this minimum to the patient, something like a facet causing the problem, or the dynamic stabilization of the spine coming in a big time nowadays with the dynamic rods, dynamic pedicles through, this will have a very big role in that scenario. But yes, I think if something like this can work out for a diagnostic purpose, it will be a great thing for the patients.
Yes, definitely. Shanawaz, do you have anything to add?
Nothing. Everything is talked about. So I don't have anything.
Uh, Dr. Divakar, anything from your side?
It is all covered by both Viral and Pramod. Nothing else to add. Had a good session.
So I would like
So
to thank.
I would like to congratulate Dr. Priya for giving us an opportunity to listen from the pain medicine point of perspective, how to deal with facet-related pain. I have learned my bit of lessons today that you can treat facet joint pain by different modality other than the facet fusion surgeries. We really don't do, but then if you can narrow it down to the facetogenic back pain, I know whom to refer to my cases.
Thank you so much, Dr. Pramod. And I would like to thank all the panelists as well as Dr. Ashok Sham sir, as well as as well as Mr. Rahul Chaube for the technical support. And thank you all for a very good discussion. I think we have had a very good knowledge session today. Thank you all and bye.
Thank you. Thank you very
Thank you very
much.
much for the invitation.
Thank you all from our.
Thank you. Bye.
Bye.
So we can leave now. Huh?
Stop recording, I think. So, Dr. Shanawaz, Dr. I don't know, Dr. Viral has left already. But nice talking to you guys, and it was a great input from